Are you pregnant and about to have your group beta strep test or GBS swab? Or are you already GBS positive per your provider? And what does that mean? I'm going to be breaking that down in this video. Welcome to the MamasteFit YouTube channel. I'm Roxanne and I'm a labor and delivery nurse, and I'm going to be breaking down what is GBS or group beta strep, why do we test for it during pregnancy, and if you're positive, what does that mean for your birth, and what does it mean for your baby? So GBS is group beta strep is a bacteria that lives in our guts, but 25% of us kind of have that GBS just naturally in our guts, just live in there. And this can increase during pregnancy. The amount of GBS can increase during pregnancy in some of us. The problem is that with that GBS increase, this can then transfer down from just our gut down to our vagina and our rectum. For us, we're probably not going to have any symptoms. If anything, maybe you'll have some UTI symptoms. But other than that, we don't have symptoms. We're like in this like symbiotic relationship with the GBS. But the issue comes when baby is born vaginally, that there is an increased risk that that GBS bacteria can then transfer to our babies, and then babies can develop early onset GBS illness or disease. The issue with that is that our immune system's fully mature by the time we're having a baby. Our body can respond to localized infections and kind of fight it without us having maybe any symptoms. With babies, their immune system is not as fully responsive as ours. There are two main responses within our immune system. There's other little ones, but like the two main ones are the innate immune response and the adaptive immune response. The innate immune response is something that we're born with. And it's like when there's bacteria, our body creates a whole body response to that bacteria. It's very systemic, full body, and it attacks it. But it can lead to us getting a lot sicker, a lot quicker. Whereas an adaptive immune response is not present at birth and takes some time to develop, about 2 years. This is our learned immune response to antibodies that our body has created from previous exposures, and it can be more localized. So if the bacteria comes in through your nose, the response will go to the nose versus, again, that innate immune response is like whole body response. This is why anytime a baby really does get sick, they're usually going to be sicker than anybody else because of the fact that their immune system is just not as fully advanced as ours. That adaptive immune system has not fully developed and learned how to respond to different things. It's that innate immune system. So when they're fresh out of the womb, if that GBS did transfer to them and then they developed this GBS disease from it, they can get sicker quicker, to leading to pneumonia, meningitis, or even sepsis in these babies. And we usually will see symptoms within the first hour of life. So they come out and they start displaying signs that they're sick pretty quickly. So because of that increased risk of these babies developing that early onset GBS disease, this is why the recommendation is for everyone to get screened for GBS during pregnancy, ideally around that 36 to 37 mark, because we could have it and not even know. So what it is it's a swab that goes from your vagina to your rectum, and they send the swab off, and it comes back in 48 hours with the result of either GBS positive or GBS negative. The other option to be considered GBS positive is if you had a urine anytime during your pregnancy and the urine came back positive for GBS in the urine, then that is another reason that they would consider you GBS positive. And if it happened before 36 weeks, they would actually just not even do the swab because they would just consider you GBS positive. The reason that they do the swab at 36, 37 weeks, though, is that GBS can be transient. It's like cyclical. Sometimes it's there, sometimes it's not there. So it kind of goes in like almost like 5-week cycles where it's there. So they test for it at 36 to 37 weeks. One, because it takes 40 hours for it to come back. But two, because if it's present at 36, 37 weeks, the likelihood of it still being present at birth is like 80 to 90%. That you're still going to have GBS at the time that you give birth if we test around that time period. So we're trying to like catch all of the GBSs. But the likelihood of you still having that GBS, if it was found in your urine in earlier part of pregnancy, is still kind of in that high range of like 80 to 90%. You're still likely to have it because that overgrowth is so high that it's also in your urine. So those are the two ways that you can be considered GBS positive. One, the swab at the end of pregnancy, or if it's found in your urine culture. So now that we know like what GBS is and why we're concerned about it during pregnancy and how it's screened, what if it comes back GBS positive? So if you're not GBS positive, you can stop watching now because you're good to go. But if you are GBS positive, there are different treatment options that they can present to you. The most recommended and the like gold standard is antibiotics during labor, so penicillin. And the reason that they give the antibiotic during labor is because they've done some studies, and that is the best time to decrease the risk of transmission of the GBS from you to the baby to then lead to GBS disease, early onset GBS disease too. And early onset GBS is the important one because there is another form of late onset GBS, but they found that early onset GBS is due to your GBS status, whereas the late onset GBS is usually due to like GBS in the environment. So early onset is what we care about. So by giving antibiotics during labor, this actually decreases the transmission rate and the amount of GBS within your body versus getting antibiotics potentially before labor. This doesn't decrease that GBS or protect the baby from contracting the GBS. So penicillin every 4 hours during labor is the gold standard treatment when anyone is GBS positive. This is given every 4 hours through an IV, and it takes about 30 minutes for that antibiotic to go in. You are considered adequately treated when you have at least had antibiotics 4 hours, like 2 doses usually because they're about 4 hours apart. But if you got an antibiotic 4 hours during your labor, this is what is considered adequately treated. So if you get it at 2 o'clock and then you don't have your baby till 6, you are considered adequately treated because you got that first dose of antibiotics at least 4 hours ago. So that is the treatment, and based off of this implementation of universal screening in the United States plus antibiotic use during labor, this brought the rate of GBS down from 1 to 2 in 1,000 births when there was no treatment, not really any screening, down to 0.22 in 1,000 births in the US by doing this universal screening and antibiotic use. So if you didn't get antibiotics, you were untreated GBS, you have a 1 to 2 in 1,000 babies chance of passing on early onset GBS. But if you're GBS positive and you were treated during pregnancy or birth, you have a 0.22 out of 1,000 births chance of your baby getting early onset. In the UK, they do a different type of screening. In some other countries, they do what's called a risk-based approach. So they don't do screening for everybody like we do in the United States. They kind of just screen a certain type of population that's more at risk. So if your baby's preterm, you have a history of GBS illness in your baby, your water has been ruptured for more than 18 hours, you've had GBS in your urine at any point, or you develop a fever during your labor, those are reasons that they would either consider you GBS positive or then screen you for GBS to see if you are GBS positive. If you have those and then they treat you during labor, your risk of baby contracting early onset GBS is 0.55 in 1,000 births. So about double what it is in the United States, which is why the United States decided to do universal screening versus the risk-based approach. But this can become a provider conversation with you because there are different numbers. It's definitely lower than 1 to 2 in 1,000. So asking your provider, like, hey, my GBS, like maybe not testing, or however you kind of want to have that discussion. Like everything is kind of up to you, share decision making, because it is rare to get that early onset GBS. It's like 1 in 2 still in 1,000. And if that's untreated, but then with the antibiotics, it's down to 0.22 or 0.5% in 1,000. Of those babies that do contract early onset GBS though, so of the 1 to 2 or the 0.22 of those babies, 6 to 9% of those babies that are term will unfortunately pass. If they are preterm, about 19% of them will pass. So of the already small number, 0.2, 1 to 2, 0.55, only 6 to 9 term babies or 19% of preterm babies will unfortunately get the GBS and will die. But of the other babies who get the early onset GBS disease, it could, if they do survive, will have some neurological conditions, long-term developmental delays, and will usually require some more longer-term medical intensive kind of treatments for those babies, long NICU stays, as well as some other treatments that they'll need to utilize as they get older. So it is a small percentage of babies that can contract this early onset disease, but if they do get it, the long-term complications as long as the mortality rate is a little bit higher. So that is why this is a conversation with your provider if you're GBS positive. Because yes, you can get the antibiotics, but that's not the right fit for everybody. You have the option to always decline antibiotics if you don't want them, but having that conversation and understanding the different numbers and the risks can be beneficial for you. What are some alternatives if you're not wanting the antibiotics is that they can monitor baby closer after baby is born. Again, most of these babies are going to show signs or symptoms within the first hour of birth, but it can show up within the next 24 to 48 hours. So sometimes knowing what to look for in these babies that are going to get pretty sick pretty quickly, so we want to respond to them as soon as we can. So things that we can look for that are like signs that something's going on with baby. Are their heart rates going to be a lot faster? So babies' heart rates are already pretty fast. It's like 120 to 160, but they're going to be faster than that. As well as they're going to be breathing faster. So babies, again, breathe faster than we do, about 30 to 60 in a minute. So they're going to be breathing a lot faster than that 60. They're also going to be a little bit more lethargic. They're not going to be as active or kind of wanting to do anything. They might be a little bit more sleepy. They're probably going to have some sort of fever, usually greater than 100.4, but sometimes it might not be a fever. They might be hypothermic, so a decreased temperature. They're going to be pretty irritable. They might have that high-pitched cry. They're not going to be as interested as in eating because they're pretty sick. They got other things to worry about, so they're not going to be very good feeders. And because they're not feeding well, they're not going to probably have very good output. So they're not going to be peeing very often. You might not even notice like this brick red dust color in their diapers pretty often because they're just not eating or drinking anything. And because they're probably breathing faster, we're also going to see signs of respiratory distress in them. So like at their rib cage, it's like sucking in, maybe see some nasal flarings, and they might even be like grunting is what we would call it. And this is when they're trying to like keep their lungs expanded by using this sound. So it's like when they're breathing because they're trying to keep their lungs expanded so they can continue to exchange oxygen. But that's a lot of work, and eventually babies cannot compensate. So like if we're able to see these signs earlier, then we're able to respond to them a lot quicker. So looking out for these signs within that first like hour, especially if not first 24 to 48 hours, if baby does not get treated, and even if baby does get treated, these are things that we want to look out for babies that are born to GBS positive moms. Other alternatives, there are some like research that supports like doing chlorhexidine like swabs during labor, like wipe downs, like decrease the GBS that's there as baby transfers through. That potentially could be beneficial to avoid antibiotics, but there are risks along with the chlorhexidine. Some people will say garlic is beneficial or pre and probiotics during pregnancy to prevent being GBS positive at all. So there are different alternatives that you can discuss with your providers. And we'll link an article from Evidence-Based Births that is really great at breaking down all things GBS, as well as a podcast episode that we did all on GBS for a lot more information than I can include in this little YouTube video. Because GBS, like while it's pretty rare, it does have some pretty increased risks for baby. So deciding and feeling comfortable with either getting antibiotics or not getting antibiotics, or doing like a little hybrid of some antibiotics, but stopping it after a few doses could be beneficial to discuss with your provider. So just to recap, what is GBS? It is a bacteria that lives within our like 25% of our guts that can increase during pregnancy just due to the hormonal changes in our body. Then this causes it to transfer down to the vagina and the rectum. The reason this is important is that because when we have that GBS down in our vagina and rectum during birth, for vaginal birth, this can transfer to our babies, and then they can develop something called early onset GBS, which is a very serious illness that usually leads to meningitis, pneumonia, and sepsis. And these babies are very sick and usually require some long NICU stays. But the risk of your baby contracting early onset GBS untreated is 1 to 2 babies in 1,000 births. Or if you are treated with antibiotics, 0.22 babies in 1,000 births if you're in the United States and have the universal screening, or 0.5 in 1,000 births if you're in other countries that do a risk-based like screening or treatment. So the risk is fairly low, but if your baby does get it, there is a 6 to 9% of infant death for term babies and 19% in preterm babies. So it is pretty serious for the few babies that get it. So this is why it becomes a really good conversation to have with your provider of what we're wanting to do, because the treatment is penicillin during labor every 4 hours. If your penicillin allergic, like if you are having like pretty substantial responses to penicillin anytime you get it, you obviously can't get that option during labor. So this is when they would do a GBS screening of what is your GBS susceptible or sensitive to, and then that is the antibiotic that they'll give you during labor. And that is an adequate option as well if you're allergic to penicillin. If you decide to get the antibiotics or not get the antibiotics, the different symptoms that we can look for in babies as a sign that they're displaying and likely have some infection is high heart rate, high respiratory rate, as well as signs of respiratory distress with like retracting, so sucking in at their rib cage or even at their collarbones, nasal flaring, or even grunting or gasping as they're breathing. We're also looking at their temperature. It might be high, it might be low, it might kind of be unstable and kind of going between the two. As well as signs with our baby like lethargy. They're going to have poor tone. They're just not really interested in like doing anything because they're just sick. They don't feel good. And they're also not going to be feeding very well. So if they're not feeding well, if they're not drinking anything, they're also not going to be peeing or pooping. And we might even see like brick red color in that diaper multiple times over 3 days. And that's going to be concerning. If you see it every once in a while, that brick red dust, one time, probably pretty normal, especially if you're not seeing anything else. But if we're seeing that along with a lot of the other symptoms, that would be concerning for that baby. And this baby is going to be pretty irritable, having a high-pitched cry. They're just not going to be having a good time if they're contracting this early onset GBS. And normally, about 90% of these babies are going to show symptoms, again, within that first hour of life. Some of them, the other 10%, it could be as late as 24, 48 hours, but most of them, it's going to be that first hour of life. So you're going to notice if your baby is pretty sick pretty early on. There are some alternatives, again, if you don't want the antibiotics, of maybe discussing with your provider of doing chlorhexidine wipes or garlic or pre or probiotics, or potentially some other things that maybe your provider knows about for GBS treatment. But discussing this with your provider can be really beneficial if you are GBS positive, especially if it's going to affect like the birth that you're kind of wanting, because an IV does require an IV pole and it does require an IV. They can do treatment and out of hospital birth. So if you're doing a birth center or home birth, GBS treatment is always an option for those places as well, and in the hospital birth. So that's all I have on GBS. There is, again, a really great article from Evidence-Based Birth all on GBS, as well as we did a whole podcast episode on GBS that will link in the description below. And if you were GBS positive during your pregnancy and birth, let us know how it went in the comments below and what you chose to do for your birth, because we would love to know. If there's a topic that you're looking to learn more about for pregnancy, birth, postpartum, like preconception, pretty much anything women's health, I would love to create a video for that topic. So just let us know in the comments below what topics you're wanting as well. And if you're pregnant or postpartum and looking for more support, check out our childbirth education course or our postpartum education course, where we discuss the science of labor and birth to kind of take away some of the mystery, but also discuss what to expect in that postpartum period, because that prep is also just as important as childbirth. Postpartum lasts a little bit longer than birth does. So you can check out all of our courses at MamasteFit.com and use code YouTube10 to get 10% off as a thank you for watching this entire video.